Today I am going to tell you how to have a good clinico-radiological approach to a patient with interstitial lung disease, or to put it in a more precise manner, a patient who presents to you with diffuse parenchymal lung disease. Very often the tendency is to look at the CT straight away and try and see what is the type of ILD and decide on treatment. The important issue here is to understand that there are possibly more than 200 causes for interstitial lung disease or diffuse parenchymal lung disease. And very often a combination of clinical examination, radiology will help you to get to a final diagnosis which may actually have a lot of bearing on the patient's treatment and prognosis. So, we will start with one case. To begin with, first it is important to understand that, like I said, there are more than 200 causes for interstitial lung disease. The interstitial lung disease is a disease which causes inflammation and fibrosis, and therefore causes extensive damage as far as the lung is concerned. It usually has a classical clinical presentation of dyspnea, dry cough, and then this patient, when you examine these patients, they have basal end inspiratory velcro type crepitations, and the X-ray shows these diffuse reticular or shadows with the haziness of the borders, the diaphragmatic border and the heart border, and the lung function shows a classical restricted effect, and you usually will rule out an infective disorder to say that this patient has interstitial lung disease. Let us start with this young person, relatively middle-aged person, 50-year-old male, an ex-smoker. He worked in a steel plant for 20 years, and then he had a history of coronary artery disease. In 2003, he had an angioplasty done, with which he recovered and was quite all right. And then again in 2012, he is presented to us with progressive dyspnea for 6 months, dry cough, there was no chest pain, palpitations or wheeze, and there were no systemic complaints. With these complaints, this patient went back to his cardiologist, who was examining him and was on whose follow-up he was, and a chest X-ray and CT was done at this point in time. Based on the chest X-ray and CT, the patient was diagnosed to have interstitial lung disease, and the report said NSIP pattern, and he was started on steroids by his treating physician. He improved, became much better, and the steroids were gradually tapered off, and by 5 months the steroids were actually stopped. This is the X-ray of the patient, and as you can see, there are these diffuse reticular shadows, especially on the bases. The diaphragmatic borders are hazy, and the heart border is also hazy, and there is elevation of the left dome of the diaphragm. This is the CT of this patient in 2012, and again you can see there are these reticular shadows. There is a thick band of fibrosis at the base, and there are these ground glassing with some degree of fibrotic reticular patches. Another cut which again shows these ground glassing with these extensive fibrotic areas. This patient, however, did not totally become all right. He again started having breathlessness, which was initially on exertion and then again on rest. He was this time re-evaluated by another physician, where a bronchoscopy and a transbronchial lung biopsy was done. The TBLB report was reported as in UIP pattern, and therefore he was diagnosed as IPF, or interstitial lung disease, because of idiopathic pulmonary fibrosis, and started on pirfenidone, azathioprine and N-acetylcysteine. There was no improvement. He was told that he has a grim prognosis and referred to a tertiary care center, and he was actually told that he has just 3 to 5 years to live. This is the CT of this patient subsequently, and as you can see, now the lesion has increased. The dome of the diaphragm is still elevated, but you can see that there is increase in the ground glassing, the haziness, especially on the left mid and lower zone, and the reticular shadows have also increased. The CT now again shows this ground glassing, extensive ground glassing, and as you go to the cuts above, you can see this dense patch of ground glassing with some degree of interstitial shadows and fibrotic areas also. So, the issue is, does this patient have interstitial lung disease, and if he has interstitial lung disease, is it IPF, and therefore how should one approach such a patient to get a definite diagnosis. Coming back to our case, we did not think he had ILD. We thought he had ILD, but we did not think it was IPF, and we treated him with steroids. He showed a very good improvement, and his subsequent scan shows only residual fibrosis, and he has been now on follow-up of treatment, and his lung function shows only a mild restrictive effect, and therefore he is doing very well. So, he is the patient who, with an appropriate diagnosis, did very well, and I think that is important to remember, that all ILDs are not IPF, and all ILDs do not have a bad prognosis. There are two very important papers which came out as far as statements are concerned. This is the ATS, ERS, GRS and ALAT statement on IPF, which is a very good paper worth reading, published in 2011 in the Blue Journal. And there was also the other journal for the other article for the idiopathic interstitial pneumonia, again published in the Blue Journal in 2013. So, these are two important documents which give us an idea as to the current status of diagnosis and management of IPF and the idiopathic interstitial pneumonias. If you look at diffuse parenchymal lung disease, which is what we are looking at, we can have different categories. We have one categories of diffuse parenchymal disease of known causes, which includes classically the connective tissue disorders, and these are diseases where you have some features to suggest a collagen vascular disorder, or this could be drug induced ILD. Then you have granulomatous disorders where you have a granulomatous infiltration in the lung. It could be sarcoidosis, it could also be hypersensitive pneumonitis. You have other forms like LAM or histiocytosis X, and then you have a huge chunk of ILDs which get labeled as the idiopathic interstitial pneumonia. Among the idiopathic interstitial pneumonia, the bulk is actually by what is known as IPF, idiopathic pulmonary fibrosis, and then you have the other IIPs like NSIP, acute interstitial pneumonia, DIP, desquamate interstitial pneumonia, respiratory bronchiolitis, interstitial lung disease, COP, cryptogenic interstitial pneumonia, and the lymphocytic interstitial pneumonia. Now, if you look at the revised classification, it is basically we have major IIPs, which is idiopathic pulmonary fibrosis, idiopathic non-specific interstitial pneumonias, the RB-ILD, the DIP, cryptogenic organizing pneumonia, and acute interstitial pneumonia. And then you have the rare ILDs, which are idiopathic lymphoid interstitial pneumonia, idiopathic pleuroparenchymal fibroelastosis, and the unclassifiable idiopathic interstitial pneumonias. So, if you are to look at the pattern of interstitial lung disease based on age, genetic factor, environmental factors, and the type of injury, you have some interstitial lung diseases which has lot of inflammation and therefore are steroid responsive and respond to immunosuppressants, and then you have those like UIP or IPF where there is extensive fibrosis and the treatment is anti-fibrotic drugs like pirfenidone and nintedanib. So, it is important to remember that if you have an inflammatory type of ILD, steroids will be very useful, but if you have a fibrotic type of ILD, you are actually looking at anti-fibrotic drug, and therefore, you have this whole range of histopathological pattern of DIP, RB-ILD where there is a lot of inflammation, to AIP and UIP where there is a lot of fibrosis, and your treatment strategy now will vary depending upon the type of interstitial lung disease that you are looking at. If you look at ILD, as per the current literature, globally in the IPF forms around 40% of the ILDs, then you have granulomatous ILDs, pneumoconiosis, allergic disorders, and miscellaneous. And among the idiopathic interstitial pneumonias, I have already told you the types that are already present. And then you have smoking related ILD. There are certain ILDs which are classically seen in smokers, RB-ILD, DIP, and Langerhans cell histiocytosis are the interstitial lung disease which are linked to smoking, and therefore, a smoking history becomes important in these patients. You have certain ILDs which are classically linked to connective tissue disorders, RA, PSS, SLE, myositis, mixed connective tissue disorder, Sjogren's and Angst-Pond, all of them are ILDs which are actually linked to connective tissue diseases. Certain vasculitis also can present. So, you can have systemic diseases which can also present as interstitial lung disease. Granulomatosis polyangiitis, which was initially known as was known as Wegener's granulomatosis, Churg-Strauss syndrome, microscopic polyangiitis, Goodpasture disease, and Behçet's are all diseases which can also present as ILD. And then you have granulomatous disorders and then environmental and occupational lung diseases. Another very important section in ILDs is the drug induced interstitial lung disease, and it is very important that in all patients who have an interstitial lung disease that you ask for history of drug intake. And it's in our country, it is important not only for allopathic drugs, but even if the patient is taking Ayurvedic drugs. Some Ayurvedic drugs have heavy metals or other stuff which can lead to interstitial lung disease. So, drug history is very important, and it is important to remember that various drugs like chemotherapy drugs, methotrexate, bleomycin, biologicals, antibiotics, in the cardiovascular section, amiodarone, anti-inflammatory drugs, and even drugs which are given for lung cancer like Geftinib, all of them can cause interstitial fibrosis, and the side effects of these drugs are interstitial lung disease, and therefore, drug history is very, very important. Then we have the inherited ILDs, and that is why family history sometimes becomes important. If you have a patient who has a relative who is diagnosed with IPF and this patient comes with ILD, it is likely that this could be familial ILD and this may be a family which has IPF. Same goes true for patients who have tuberous sclerosis and neurofibromatosis, and then you have the rare forms of interstitial lung disease like LAM and alveolar proteinosis. So, when you start looking at a clinical approach to ILD, when a person comes with interstitial lung disease, the first thing that you have to look at is the duration of the interstitial lung disease. How long has the patient been symptomatic? There are some ILDs which have an acute onset occurring within days, or they have a subacute onset between 4 weeks to 12 weeks, and there are certain ILDs which are chronic, going on for more than 3 months. And then you have certain ILDs which are episodic, they respond on their own or with treatment, but come back. The first patient that I showed to you, the index case, had an interstitial lung disease which responded to steroids, but it came back. So, it is important to keep that in mind. Among the acute ILDs, remember interstitial lung disease presents acutely, can be infective, and a lot of viral infections can lead to bronchiolitis, can lead to inflammation of the interstitium, and that can cause an acute ILD. It can be allergen, it can be toxin related, especially cytotoxic drugs. Vasculitis can have an acute presentation, and AIP can be related to trauma and sepsis. The episodic ILD, if you have a patient who has interstitial lung disease which comes and goes, think of pulmonary eosinophilia, think of vasculitic syndromes like Churg-Strauss, Wegener's or SLE, think of hypersensitivity pneumonitis and cryptogenic organizing pneumonia. These are the interstitial lung disease patterns which can be episodic, and you may have a patient who responds and then relapses and responds, and then you may think of these type of interstitial lung disease. You have a whole group of interstitial lung disease which may be part of systemic disease, the CTD related ILD, the vasculitic, sarcoid, and in various malignancies, and then certain miscellaneous disorders also can be related to that. Another important section which we need to keep in mind is exposure related interstitial lung disease. So, it is important to take a history of exposure, and then this can be related to coal, silica, asbestosis and aluminum. You can have non-fibrogenic dust exposure like siderosis, you can have granulomatous or fibrogenic dust exposure like berylliosis, and then the classical organic dust exposure, which is the farmer's lung, the bird fancier's lung. All of them can lead to a picture of hypersensitivity pneumonitis, where there is interstitial lung disease with airway involvement. So, you have interstitial lung disease with air trapping, bronchiolitis, which classically suggests a diagnosis of hypersensitivity pneumonitis. And then we have the chronic ILDs which may be idiopathic in nature like IPF, sarcoid, alveolar proteinosis and LAM. So, after you look at the onset, the second issue is to look at the progression of disease and the age of onset. Remember, IPF is a disease which occurs in the older age group. Some people actually look at IPF as a disease of aging and a disease of the elderly, and it is said that IPF occurs because of increasing IPF is there because of an aging population. So, IPF usually occurs in people over the age of 50. If you have a patient who has a UIP pattern on CT scan, but it is say 20-25 years ago, very unlikely that this patient is IPF. It's the ILD is related to some other cause which is having a UIP pattern. Look at the risk factor for smoking. I told you certain ILDs are smoking related. Then look for rheumatological symptoms. They may be very, very subtle. You may have just a history of Raynaud's phenomena. Patient may say that during winter months there is slight bluish discoloration of the nails, and that's all. You may have mild ocular symptom and you may have some skin lesions. Occupational history, like I already said, is very important. History of hobbies and travel, past medical history, especially of chemotherapy and history of recurrent pneumothorax, and then drug history, especially alternate medicine, is also very, very important. So, when you are looking at these patients on examination, a detailed history and systemic examination is very important. Look for possible clues which may give you an idea to the underlying ILD. First thing that we always look for is presence of clubbing. Clubbing is present in about 60% of patients with IPF, but it can also be present in patients with chronic hypersensitivity pneumonitis, rheumatoid arthritis, asbestosis. And then classically what is general teaching is that in a patient of ILD, when you auscultate the back, you will see the fine and inspiratory velcro crepes. That is classically seen in IPF. It is also seen in CTD and asbestosis. But there are other ILDs where this may not be there. For example, in sarcoidosis and hypersensitivity pneumonitis, you will not see these type of crepitations. Similarly, there are certain ILDs where you can have wheezing, you can have rhonchi which are present on auscultation. So, if you have an ILD where you are also hearing wheezes, think of Churg-Strauss, think of eosinophilic pneumonia, think of airway involvement along with the ILD like bronchiolitis, which is also a possibility. So, you can have a lot of extrapulmonary symptoms that you need to look at. Look for recurrent oral ulcers, which may tell you that this may be lupus and overlap syndrome. Look for oral history of ocular and oral dryness, which may give you an idea of Sjogren's or overlap syndrome. look for skin or facial tightness, look for rash, joint involvement, arthralgias, thickening of skin, myalgias, facial lesions and renal involvement, and this will give you some clue as to what could be the underlying ILD, whether it is a connective tissue related ILD, whether it is LAM or it is a pulmonary renal syndrome. To give you an idea of what you really need to look at, I am going to give you some cases. This is a patient who presented as a 50-year-old male, non-smoker, had fever, breathlessness and dry cough for 4 months, treated with antibiotics, there was no improvement, chest X-ray and CT was done and he was diagnosed as hypersensitivity pneumonitis. He was advised steroids and referred for evaluation. This is the X-ray of this patient and you can see there is a diffuse ground glassing which is present in both the lungs. This is the CT of the same patient and you can see there are these reticular and ground glass patchy opacities which are present in the upper and the mid zone, and they are also in the perihilar distribution, but there is some sparing as far as the periphery of the lung is concerned. This is another view of the same patient and you can see that there is these ground glassing which are present diffusely. History again was something that is very important, a detailed history was taken. This patient gave a history of recurrent infection that he was having like this in the past, possibility of Pneumocystis carinii infection was considered, sputum was sent which was positive for Pneumocystis carinii, a CD4 count was done which came out as only 13, and this patient was diagnosed to have AIDS with Pneumocystis jirovecii pneumonia. So, important issue to remember that certain infections can also mimic interstitial lung disease. Another case, this is a 27-year-old girl who came from Mathura almost about 6-7 years ago. She had presented with polyarthralgias and fever for 4 months, hemoptysis for 2 days and increasing breathlessness and drowsiness for 2 days. She was admitted in the casualty with respiratory failure. There was also a history of query hematuria 3 months ago. As a matter of fact, she had told her GP in Mathura that she had some degree of blood in the urine, but he had thought that this was related to her menstrual cycles and did not give it much importance. When she came to us, she was pale, she was tachypnic, her hemoglobin was only 5.3, her serum albumin was 2.7, urine RBCs were 3+. This is the X-ray of the patient where you can see there is this diffuse shadows which are basal, showing bilateral interstitial shadows. She was given 3 units of blood outside and her dyspnea actually worsened, because actually she was given whole blood rather than packed blood, and she was referred to us as bilateral pneumonia with septic shock. She came to the casualty, she was very drowsy, her father was very worried. As a matter of fact, he drove her from Mathura and thought that she would not even make it to the AIIMS casualty. This is the CT of the patient which was done subsequently, and as you can see there are these diffuse reticular shadows which are present in both the lung fields. On investigation, her hemoglobin was 5.2, she had some degree of leukocytosis, her urea creatinine were all right, bilirubin was okay, there was mild elevation of ALT, but look at the urine examination. Urine showed 2+ proteinuria, there were 80 to 90 RBCs, there were 5 to 10 WBCs, and 24-hour urine albuminuria showed 4.48 grams. She had nephrotic range proteinuria. This patient has ILD, but what is the likely diagnosis? And if you had just looked at the lungs and not looked at the whole picture, you would probably have missed the diagnosis. So, we reviewed the history, there was no cough, there was significant systemic features, she even gave a history suggestive hematuria in the past, she had diffuse interstitial lung involvement and there was hematuria and proteinuria. So, she had possibly a pulmonary renal syndrome and with alveolar hemorrhage which was causing these interstitial shadows. So, she was very sick at this point in time, so we gave her 3 pulses of methylprednisolone, 1 gram IV followed by oral steroids, and then subsequently we investigated her, did a bronchoscopy and a kidney biopsy. This is the bronchoalveolar lavage of the patient, and as you can see it's full of blood, there are hemosiderin laden macrophages, and if you look at the transbronchial lung biopsy, it shows alveoli again showing full of the blood and with hemosiderin laden macrophages. We did, the TBLB also shows the same thing, fresh hemorrhage, and iron stain is also positive. The kidney biopsy shows focal proliferative glomerulonephritis, and there are also crescents that you can see that are present in the kidney biopsy. And therefore, based on this, a diagnosis of ILD with vasculitis was considered. This patient had microscopic polyangiitis, but this patient actually almost lost her life because a detailed examination was not done and a lot of things in the history were missed. So, whenever you have a patient with interstitial lung disease, a detailed history is crucial when you are looking at a systemic disorder which may also have interstitial lung disease. Another case, this is a 28-year-old male who came to us from Bihar. He has presented with progressive breathlessness for 1.5 years, increasing shortness of breath for 6 months. No history of cough, wheeze, hemoptysis and fever. He was a laborer working in Delhi now, chronic smoker, no alcohol intake. General physical examination was normal except that he was very thin built and emaciated. His BMI was on the lower side. His chest examination showed impaired percussion node on the right side and there were bilateral Krebs and bronchi. Other system examination was normal, routine investigation was normal. This is the X-ray that this patient has. As you can see, there is extensive fibrosis present in the upper zone and there is some degree of hyperinflation with the diaphragm being sort of flattened in the lower zone. The CT, this is the CT he was carrying with him from Bihar, which shows these fibrosis, but you can see that there is a pneumothorax also on the left side. Again, the lower cortex showing fibrosis with pneumothorax, and this is the CT which we had done here, which shows again dense fibrosis with pleural involvement, dense areas of parenchymal fibrosis. There is also a chest tube now because he dwelt to pneumothorax on the other side. This is the lung window again showing areas of fibrosis with infiltrates which are present, and other cuts showing extensive fibrosis with some degree of reticular shadows. So, this patient has ILD with upper lobe involvement, dense fibrosis and has a pneumothorax on both sides. What would be the likely cause and what will help to establish the etiology in this patient? So, if you had this patient, what would be the most important question that you would ask him? The most important question would be his occupation. So, what was his work? And he gave a history that he worked in a stone crushing plant for 4 years, almost 5 years ago, and during that time he had developed an occupational lung disease, and this is an ILD because of silicosis. So, if you have that history, the diagnosis becomes very easy, otherwise you will not be able to make a definite diagnosis. So, this is occupational, and exposure history is important when it comes to working up these patients with interstitial lung disease. Then when you start looking at your patients, do a thorough examination. Look for erythema nodosum. You can find that in your patients. It's not that rare. If you look, and it's classical for sarcoid, CTD, and Behçet's. Look for a maculopapular rash, which may give you an idea of sarcoidosis or a collagen vascular disorder. Look for various other rashes. For example, cafe au lait spots may give you an idea of neurofibromatosis. Telangiectasia may give you an idea of scleroderma. And if you have subcutaneous nodules, it may give you an idea of rheumatoid arthritis or neurofibromatosis. All patients with ILD should have an eye examination. If there is uveitis, again it helps you and gives you a clue that there may be sarcoid or Behçet's. Look for scleritis, keratoconjunctivitis, look for lacrimal gland involvement, and all of this will give you an idea of whether could be the underlying etiology for sarcoidosis, for the interstitial lung disease. Similarly, for physical examination, look for parotid enlargement, look at the salivary glands, look for lymphatic involvement. So, look for any lymphadenitis. You may pick up a lymph node, look at the musculoskeletal system, and it's also important to do a detailed examination, especially of the central nervous system and the cardiovascular system. And again, like I said, look for Raynaud's phenomena and look for digital clubbing. One important thing in interstitial lung disease is to do a detailed skin examination. You may find some lesion in the skin which may have not only help you or give you a clue to the diagnosis, it may also give you a site to biopsy, and that may tell you what is the underlying disorder if you are able to do a biopsy. So, this is some cutaneous lesions in some of our patients. These are nodular lesions, and as you can see, this is a lady who had one of the scars, actually one of the lesions over an old scar that she had, and this is basically seen in patients with sarcoid. This is another patient who has sarcoid, and you can see these classical cutaneous lesions which are present both in the hands and the leg. These are two patients who have classical erythema nodosum. One of them is a staff nurse who presented with just dry cough, shortness of breath, and these classical nodules on the shin, and a chest X-ray shows bilateral hydral adenopathy, and based on this I think the diagnosis was very obvious that she had underlying sarcoidosis. Similarly, in another patient you can see the scaly lesion present on the limb and on the face, again another lady who has sarcoidosis. Interestingly, about 5 years later her son also came to us with classical hilar adenopathy, and this is a case, this sort of a familial sarcoid that we have. These are other lesions that you can see, classical lesions on the back in patients with sarcoidosis, and then you have these classical lesions of the CTD, especially in patients with scleroderma. You have a pinched out nose, you have a salt and pepper appearance on the skin, telangiectasia and calcinosis. All of these will give you an idea that you are looking at a patient with scleroderma, and that may be very clear as far as what is the cause of the interstitial lung disease. Also look for Raynaud's phenomena, and some of these patients will have sclerodactyly or will have trauma and lesions at the tip of their fingers, or there could be a loss of the volar pad of fat. Again, all of these on examination will give you an idea that you are dealing with a patient who has an underlying connective tissue disease. You can even look for gangrene, and you can look for digital infarcts and ulcers, and very often this is classically seen in patients with a connective tissue disease. So, this is as far as the evaluation of these patients is concerned. So, very important to take a detailed history of drugs, history of the occupation that they are doing, do a detailed examination, especially the skin and the eye, and a general examination, because that will give you a clue to what could be the underlying cause of the interstitial lung disease. When it comes to investigation, broadly we do investigations for two things. One is, what is the degree of disability does this patient have because of the ILD? And for that we will do a lung function, you could do a saturation, you could look at the ABG, and with the lung function you would do a diffusion capacity or a DLCO also. And now traditionally we will also do a 6-minute walk test to get an idea of what is the fall in saturation on walking 6 minutes and what is the distance a patient can walk. These are important tests because they will also give us an idea when we follow up these patients. And then we do some tests to give us a further idea as to what is the cause of the interstitial lung disease, and that includes a chest X-ray and an HRCT. The HRCT is probably now the standard of care for all patients with interstitial lung disease, and it is a must that it should be done. Then in some patients, when indicated, a bronchoscopy is done. You can do a BAL, a TBLB and an EBUS. And in some patients you may need a lung biopsy, which is now usually a VATS guided lung biopsy to get to the diagnosis. So, useful tests in suspected ILD, if you have a patient with underlying, you suspect a connective tissue disorders, a baseline test of ANA, rheumatoid factor, anti-Jo, SEL70 antibody should be done. You must do some test if you are thinking of dermatomyositis, a vasculitic workup, a P and a C ANCA should be done. If you are looking at diffuse alveolar hemorrhage, then GBM antibody should be looked at. For sarcoidosis patient, an ACE level is important, and for patient with hypersensitive pneumonitis, you must look for serum specific IgG antibodies. BAL is not something, or bronchoscopy is not something which is required in all patients. It is currently not recommended in classical patients with IPF, but it has its usefulness, and therefore you must consider a bronchoscopy in patients when you are suspecting sarcoid, eosinophilic pneumonia, alveolar proteinosis, LCH or LIP, because it will help you to give a diagnosis. There is also in a whole guidelines published. This is the official ATS statement on the clinical utility of bronchial lavage, published in 2012. It is worthwhile to go through this article, but it will tell you what is the utility of lavage in current status as far as patients with ILD are concerned. But lavage can also be useful not only to make a diagnosis, but also as a therapy. And to give you an example, this is a girl who came to us from Nepal. She is a 26-year-old non-smoker from Nepal. She came to us with dry cough for 1 year, shortness of breath for 4 months, and on examination her chest showed bilateral crackles. She was treated with antibiotics for pneumonia, and when she came to us, the resting saturation was only 78%. Her alveolar arterial oxygen gradient was 187, and she was evaluated, and a CT and a BAL was done. This is the X-ray that she had. This is the CT of this patient, and this classically shows what is known as a crazy pavement appearance. As you can see on the CT scan, there is ground glassing with interlobular septal thickening, and we did a BAL in her. The BAL was positive, and it showed acellular proteinaceous material, giving us a diagnosis of alveolar proteinosis. So, the treatment for alveolar proteinosis can be a whole lung lavage, and we took this patient up for 3 sessions for a whole lung lavage. This is the milky fluid that you get when you do a lavage in these patients, and you can see that it has cleared up gradually, and post whole lung lavage her saturation improved to 96%, her 6-minute walk test became 307 meters, and her alveolar arterial gradient, which was around 187, came down to 86. We sent her GM-CSF antibodies level, which were also elevated, and therefore this further gave us a diagnosis of alveolar proteinosis, and she was actually discharged off oxygen. We have now almost 8 or 10 patients who we have done a whole lung lavage in alveolar proteinosis, and one such patient has required almost about 40 to 60 liters of wash to get the proteinaceous material out of the lungs. So, this is the CT of the same patient. As you can see, the pre-procedure and post-procedure, as you can see, there is a lot of clearing as far as the shadows in the lung is concerned. This is another patient of ours whom we have done almost 60 liter lavage, and you can see the bottles which are all lined up, and gradually with time the fluid has cleared as we have done a lavage of around 60 liters. The other utility of bronchoscopy is in diagnosing sarcoid, and this is an old data that we looked at in 2002 when we looked at the yield of our patients of around the yield of transbronchial lung biopsy, and in that series in almost 136 patients we were able to get a diagnosis of sarcoid by a transbronchial lung biopsy. We also used to do, and we regularly do, bronchial biopsies, and this helped us in getting a diagnosis in 15 additional patients where the TBLB was negative, but the bronchial biopsy actually showed a non-necrotizing granuloma. So, we had a yield of almost 77% in making a diagnosis of sarcoidosis if we just did a TBLB and a bronchial biopsy, and this is in the era where there was no EBUS and we were not doing EBUS with Rose. In that in series in 2002, 5 patients required a VATS guided biopsy, and in 31 patients we were able to get a diagnosis by a skin biopsy, and that is why I keep telling you that it is important to look for extrapulmonary site of involvement, because sometimes they will help you to get a diagnosis. Now, of course, a lot of these patients will undergo an EBUS TBNA with a rapid on-site evaluation, and this is data that we looked at our initial of EBUS in patients who had mediastinal adenopathy, and again you can see that the yield is now very high, but it is almost similar to what was present in the initial era of a TBLB and endobronchial biopsy. The other important thing is to look for cardiac involvement, and some of these patients may present with palpitations, and this is one patient who came to us with was referred to us by the cardiologist. He was seen in cardiology where he had a complete heart block and they thought it was sclerodegenerative heart block, but the X-ray did not look very good, and so he was sent to us for evaluation. The X-ray showed these classical nodular infiltrates with peribronchovascular and fissural involvement, which classically suggested sarcoidosis. So, this patient had interstitial lung disease which was secondary to sarcoid, and there was also involvement of the heart in the conduction system of the heart, which was basically he had cardiac sarcoid, and you can see this CT which was done, which shows the pacemaker in place, and you can see the nodular shadows in the lung. So, it is important to remember that sometimes you can have patients who have cardiac sarcoidosis who may present with arrhythmias, palpitations and interstitial lung disease, and unless you suspect the two, you will miss the cardiac sarcoid and therefore not treat the patient appropriately. When you look at the HRCT, which is again one of the most important diagnostic tools in the armamentarium for the diagnosis of interstitial lung disease, the first thing that you look at is the lung volume. Is the lung normal, or is it shrunk? Then you look at the pattern of distribution. What is the involvement of the ILD? Is it more upper lobe, mid zone, or is it lower lobe dominant ILD? What are the type of shadows? Are there reticular shadows? Are there nodular shadows? Is there mosaic attenuation, or is there honeycombing? So, if you have low lung volumes, if the lung seems to be shrunk, you find the diaphragm has gone up and the lung is looking as if it has shrunk, then you are looking at an IPF or a CTD related ILD or a chronic HP, chronic eosinophilic pneumonia, or a desquamate interstitial pneumonia. On the other hand, if you have an ILD where the lung volume is preserved, then you should think of RB-ILD, IPF with emphysema, LCH, LAM or sarcoidosis. These are the ILDs in which the lung volume is actually preserved. If you have an ILD which is upper zone dominant, think of sarcoidosis, silicosis, HP, LCH and cold workers pneumoconiosis. So, this is basically an upper zone predominant ILD that you can see, and like I said, pneumoconiosis, sarcoidosis, LCH and Angst-Pond are the common causes. If you have a lower zone predominant ILD, think of IPF, especially if it is peripheral subpleural, think of CTDs, asbestosis, DIP and chronic HP where there is more of lower lobe or lower zone involvement. If the ILD has peripheral predominance, there is central sparing but more peripheral involvement, again think of IPF, COP or chronic eosinophilic pneumonia. If there is honeycombing, it is thought to be very suggestive of UIP pattern and you must think of IPF. But like I said in the beginning, all UIP is not IPF, and therefore honeycombing can also occur in CTD, it can occur in chronic HP and it can occur in sarcoidosis. And if you have migratory shadows which are interstitial, think of Loeffler syndrome, COP, hypersensitivity pneumonitis and ABPA. But look beyond the lung in your CT scan. So, if you have a CT scan, just do not look at the interstitial pattern, look for the mediastinum. If there are mediastinal nodes, think of sarcoidosis, silicosis, and occasionally in connective tissue disease also you can have mediastinal nodes. If there is pleural involvement, you have ILD, but there is also pleural involvement, think of CTD, radiation induced pneumonitis and asbestosis. And if you have a patient who has recurrent pneumothorax, then you are looking at LCH, LAM or tuberous sclerosis. So, common radiological findings, you can have diffuse reticulation on HRCT, and this can occur in UIP, NSIP, all connective tissue diseases, chronic HP, asbestosis, all of them can have a diffuse reticular shadows. It can also occur in drug induced ILD. And this is the diffuse reticular shadow that you will see on a CT scan, which will tell you that this is just a non-specific picture, it can evolve into anything. If you have ground glassing, it should suggest NSIP. Ground glassing is against the diagnosis of UIP and IPF. It can occur in AIP, it can occur in RB-ILD, COP and subacute hypersensitivity pneumonitis. So, this is the ground glassing. This is a CT which shows you classical ground glassing that you can see. Another CT which shows extensive ground glassing which can occur in some patients. If you have consolidation, think of COP, polymyositis, AIP, acute HP, and certain drugs also, drug induced ILD can lead to a ground glassing or a consolidated picture, and it can also occur in what is known as alveolar sarcoidosis. So, just to give you another case, this is a 15-year-old girl who came to us from Odisha. Actually, the first time she came to us in 2009. She had high grade fever and dry cough in 2009. She was diagnosed in Odisha in Bhubaneswar as having pneumonia. She received multiple antibiotics, ATT, antifungal without any response, and in 2010 she came all the way from Odisha to us. She was re-evaluated, ATT was stopped, antifungals was stopped. She had this dense consolidation. We did a CT guided biopsy from here. It showed a classical cryptogenic organizing pneumonia. She started her on steroid. There was a dramatic improvement. Her chest and her X-ray totally cleared up. She used to come on regular follow-up. By 2011, I had tapered off her steroids and stopped them, but her father brought her back 3 months later with a relapse in 2011. This time she had these dense shadows where you can see this clearing in the center, and this is classically what is known as the reverse halo sign. So, she had a classical reverse halo sign. She was started this time on a combination of steroids and azathioprine, and again we tapered it off slowly, and she had complete resolution and remained asymptomatic till 2013 with a minimal dose of steroids. Her father used to ring me up from Bhubaneswar. He rang me up and told me that she is totally all right and on 5 milligram alternate day, and can I stop it because she is not wanting to take it, and we stopped her treatment in 2013 December. In July 2014, she had severe respiratory distress and fever. She was diagnosed outside as query fungal pneumonia, worsened on the day of admission. As a matter of fact, she came to the OPD, she was very breathless. I admitted her immediately, and by the evening, when I went for the evening round, she had been intubated. She had gone into severe breathlessness and she required mechanical ventilation for 23 days. This is the CT that X-ray that she came to us with, and you can see these diffuse alveolar shadows present in both the lungs. This is the CT of the patient, and as you can see, the reason why she deteriorated was she had bilateral pneumothorax. So, this is a very bad picture. You can see the lung is totally consolidated and she has pneumothorax on both sides. We had a big discussion, is this a relapse of COP or is it a fungal infection, because she has been on immunosuppressant for a long time. Keeping her past history in mind, she was given a pulse of steroid, and again she improved dramatically. She was discharged after 1 month of hospital stay and is now again on very low dose steroids and azathioprine. Her X-ray done 1 week later actually showed total improvement. There was no residual shadow. She had improved and she had become asymptomatic. So, this is how a lot of patients with chronic cryptogenic organizing pneumonia will behave with a relapsing course and a remission, and some of them respond dramatically and some keep having relapses. Another patient, a 31-year-old lawyer with cough and fever for 1 month, treated with antibiotics, and ATT was advised because his X-ray, if you look at the X-ray carefully, there is this lower zone infiltrates on the right side. This is the other X-ray, and it again shows lower zone infiltrate, and this lawyer's father-in-law was a doctor who kept saying that he is not responding, there is a cavity in the lower zone, why do not we start this patient on anti-tubercular treatment. If you look at the CT, and this is the CT of this patient, and again you can see this classical reverse halo sign on both sides. You can see the center of the lung, in the center the lung is totally normal, it is not that it is like a cavity where the lung has been destroyed. and this is the other view, which you can again see the classical reverse halo sign. This patient responded dramatically to steroids, was not willing for a biopsy, and therefore has done very well just on a course of steroids, but again a patient of cryptogenic organizing pneumonia with the classical reverse halo sign. Finally, you will have some patients with ILD with nodules. If you have nodules, first look at the distribution of the nodules. Are they pleural nodules or are pleural nodules not present? If pleural nodules are absent, then these are classically what is known as centrilobular nodules. And if you have pleural nodules, are they along the fissure and the septa? That becomes perilymphatic nodules, or if they have no such distribution, then they are known as random nodules. Why is it important? Because if you have centrilobular nodules, you are looking at subacute HP, RV-ILD, Langerhans cell histiocytosis. If you have nodules which are around the fissure, subpleural, perilymphatic, then you must think of sarcoidosis, silicosis and cold workers pneumoconiosis. If you have random nodules, they are distributed all over, it could be metastasis. It can also occur in silicosis, sarcoidosis, and another common cause in our country is miliary tuberculosis, where the nodules can coalesce, the miliary shadows can coalesce and look like nodules. So, this is the classical peribronchovascular nodularity that you see. This is of course the same patient who had cardiac sarcoid, and here you can see in the other scan extensive peribronchovascular nodularity. Another patient where you can see all the peribronchovascular shadows are classically showing a beaded appearance along the vessels, and you can see a lot of subpleural nodules, classical scan of a patient with sarcoid. Another patient with sarcoid, again you can see this diffuse nodularity along the fissure, and this is another patient who has this diffuse nodularity with a dense fibrotic area present on the CT scan. Then you can have ILD with cysts, and if you have cysts in your interstitial lung disease, think of Langerhans cell histiocytosis, think of lymphangioliomyomatosis, and think of lymphoid interstitial pneumonia. So, these are the type of cysts that you can see in patients with ILD, and this is one of our patients. You can see this diffuse cysts present, again another cut showing diffuse cysts. And this is a history of again the detailed history is very important. This is a 25-year-old lady who came with pain abdomen and dyspnea. She had renal lump was detected on ultrasound. She underwent resection, which was found to be angiolipoma, and then she developed acute breathlessness subsequently, and a pneumothorax was dissected, and when the CT was done, it showed multiple cysts. So, you have a patient who has pneumothorax, has multiple cysts in the lung, and has a renal lump which is a angiomyolipoma. I think you have a definite diagnosis in the form of LAM. This patient has lymphangioliomyomatosis, and this is a classical picture that these patients have. The reason why it is very important that these patients do very well with low dose sirolimus. So, you have a specific treatment for these patients with ILD, and therefore, diagnosing this is very important, because if you are treating them with steroids or immunosuppressant, they will not show a very good response. Finally, coming to IPF, which is one of the frequently seen ILD, and which is also the one which has a poor prognosis. The classical spectrum is that you must exclude other causes of ILD, that is exposure, occupation and environment, connective tissue disorder and drug toxicity. Presence of UIP pattern should be there on HRCT in patients not subjected to a surgical lung biopsy, and a specific combination of HRCT and surgical lung biopsy pattern is also required to make a diagnosis of idiopathic pulmonary fibrosis. So, this is the classical picture that you would see in patients who have IPF, which is a classical UIP pattern. For a UIP pattern, there should be subpleural basal predominance, reticular abnormality, honeycombing with traction bronchiectasis, and there should be absence of the 7 features which are listed as not suggested or inconsistent with UIP. If you do not have honeycombing, all the other features, it becomes a possible UIP. But the important thing to remember is what are the features which are against the diagnosis of UIP, and these are these 7 very important features, that if there is upper lobe predominance, if there is peribronchovascular predominance, if there is extensive ground glassing present in the CT scan, if there are micronodules or nodularity, or if there are cysts or mosaic attenuation which suggests air trapping or presence of consolidation on your CT scan, you are going away from a diagnosis of IPF, and you are looking at some other cause of the interstitial lung disease, where you may have a treatment if you were to examine your patient properly. Honeycombing, like I said, is not always IPF, although honeycombing is classically seen in UIP and in IPF. Fibrotic NSIP, drug induced ILD, asbestosis, sarcoidosis, chronic HP and collagen vascular disorder, all of them can lead to a honeycombing in the CT scan, and therefore, just the presence of honeycombing does not make it IPF. This is classical honeycombing that you will see in your patients, which shows you this classical cysts which are layered over one another, and you will, this is to show you in a more magnified version, and the lung, how the lung will look at in because of these honeycombing cysts. And this is a patient who has a lot of ground glassing, there is no honeycombing, and this is not a UIP pattern. So, finally, if you have a patient you suspect ILD, first important thing is to take a history, do investigations, do a lung function and a chest X-ray. Based on this, if you can make a confident diagnosis based on a history, or you have a peripheral lesion, you biopsy and it shows a non-necrotizing granuloma, you can make a diagnosis of pneumoconiosis, CTD or sarcoidosis, and you would start appropriate treatment. But more often than not, you would get an HRCT. Based on your HRCT, if you can make a confident diagnosis, it could be IPF, HP or LAM. Again, you can start treatment without doing anything else. If you are still not sure of your diagnosis, consider a bronchoscopy if you think that will help. You can do a BAL, a TBLB, and if that is helpful, you may get a diagnosis of sarcoid, eosinophilic pneumonia, alveolar proteinosis like the case that I showed to you, HP and COP. And if that also is not helpful and you are still wanting to get to the diagnosis, then you must consider a lung biopsy, you should consider a VATS guided lung biopsy. A lot of centers like ours are now started doing a cryobiopsy, which also gives a larger tissue and is less invasive, and I think maybe over a period of time cryobiopsy will also become an important tool for getting a tissue diagnosis in these patients with interstitial lung disease. So, to conclude, ILD represents a heterogeneous group of disorders. Remember, so all ILDs are not IPF and all UIPs are not IPF. Detailed history and examination and lab workup may provide important clues to etiopathogenesis. So, like I said in the beginning, do not just look at a patient and say he has ILD and go straight away to the CT scan. Do take a detailed history, do examine your patients and then have a detailed workup planned, because you may get a clue both in your examination and in the lab workup that you do as to what could be the cause of the underlying ILD. HRCT pattern is an important tool in establishing the likely diagnosis, and therefore, it is important to get a HRCT, and when you are getting an HRCT, get a proper HRCT, make sure there is an inspiratory and expiratory scan that is done, because that will give you an idea of the degree of air trapping, and therefore, not just asking for an HRCT is not good enough. Give special instructions on the type of HRCT you require. Sometimes people even will ask for a prone scan if they feel that this is a mild ILD, but the shadows may be more dependent. Some patients, like I said, may need an open biopsy, and therefore, you have no option but to go get an open biopsy, which is usually a VATS guided biopsy or a cryobiopsy. And coordination between the clinician, the radiologist and the pathologist, what is now known as a multidisciplinary approach, is very useful in some patients, because that will help you to get a definite diagnosis, and that is something that you must keep in mind, that get everyone on board, talk to the pathologist, talk to the radiologist, and therefore, get a better idea as to what is the pattern, and therefore you would be able to offer the best treatment to your patients. Thank you very much.